So vasopressin is a powerful vasoconstrictor. It mainly works on the V1 receptors, which are on the smooth muscles and also on the efferent arterioles of the kidney. So in septic shock, renal blood flow is actually normal or increased, and this is due to there's vasodilation of the capillaries, which actually bypass the kidney, and there's also vasodilation of the efferent arteriole, which actually causes a shunting of blood through the Bowman's capsule, and it actually causes a lower GFR. So vasopressin was looked at because it causes efferent arterial vasoconstriction, which in turn increases GFR. So why was this study done? There's currently already 4 randomized control trials that have been done that have shown that vasopressin actually improves or prevents renal failure and septic shock. So we're just going to go over the trials now. So the first one is the VANISH Trial, which was published in 2008. This was a large randomized control trial. It had over 700 patients, and it was powered towards vasopressin and its effect with mortality. The VAST trial was the first trial to show that vasopressin infusion was actually safe. They compared vasopressin to Levophed, and the adverse event rates were the same for vasopressin and Levophed. So in this trial, they were randomized to receive vasopressin or Levophed in addition to conventional catecholamine pressors if they needed it to maintain MAP goals. In this study, they showed that patients noted to have less severe septic shock. There was a significant reduction in mortality in patients in the vasopressin group, and there was no difference in mortality between vasopressin or Levophed in patients with severe shock. And there was also a reduced mortality in patients that were treated early with vasopressin, specifically within 12 hours of shock onset. And vasopressin also led to lower rates of progression of renal failure, and serum creatinine actually improved. So they were unsure why these results happened in the trial. They thought maybe the less shock, the patients that were classified as having less severe shock received vasopressin earlier in the trial, or maybe they thought that the patients with severe shock needed higher doses of vasopressin. It was noted that in this trial, the dose that they used was 0.03 units. So this is kind of where the VANISH trial came into play. So then the next trial was in 2002 with Patel with beneficial effects of short-term vasopressin infusion during septic shock. It was 24 patients that were randomized to either have Levophed or vasopressin for 4 hours, and they monitored urine output and serum creatinine, and both improved in the vasopressin group. But I just want to make a note that the vasopressin rate that they used was 0.08 units per minute, so significantly higher. The next one is vasopressin and norepinephrine in hyperdynamic septic shock. And so this randomized 23 patients. They were either randomized to vaso or levo, and the patients in the vaso group doubled their creatinine clearance. The dose for vaso in this group was ranged from 0.04 to 2 units per minute. So the next one was continuous terrapressin versus vasopressin infusion in septic shock. This was 45 patients that were randomized, and the vasopressin group had stable creatinine, and Levophed had elevated serum creatinine. So also steroids have been used as adjunct therapy in septic shock. Low-dose hydrocortisone has repeatedly been shown to reduce catecholamine infusion rates, but there hasn't really been a study that shows that there was an improved survival with steroids. So there was a subgroup analysis from the VAST study which reported statistically significant interactions between vasopressin and steroids, and that whenever vasopressin and steroids were used together, there was a significantly lower mortality than whenever Levophed and steroids were used. And that, in contrast, patients that just received vasopressin with no steroids had an increase in mortality. So the VANISH trial is actually going to look at steroids as well. So it was a randomized control trial. It was done from 2013 through 2015 in the United Kingdom. 408 patients were randomized. It was done across 18 just generalized ICUs. They had to have septic shock, so they had to have serous criteria with source of infection, still remained hypotensive despite adequate fluid resuscitation. And they were randomized to 4 different groups. They were randomized to vasopressin plus steroids, vasopressin plus placebo, which actually was just normal saline, levofed plus steroids, or levofed plus placebo. They had to be enrolled and started on their drug within 6 hours of onset of shock, and from the study, everyone was enrolled and started on their drug within 3 to 3.5 hours. And the study also looked at higher doses of vasopressin, like we talked about earlier from the VANISH trial. So once patients were maxed out on their drug, whether it was vasopressin or levofed, if their blood pressure was still low, they would go to the next tier of drugs, which was either steroids or normal saline. And after that, if their blood pressure was still low, then they could use catecholamine vasopressors at the physician's discretion to maintain MAP goals. And those would be the first to be weaned off once shock resolved. And then blood and urine was collected on days 1, 3, 5, and 7. And the primary outcome that they looked at was kidney failure-free days during the first 28 days after randomization. So this is the criteria that they used to define kidney failure. You just had to have one of these to be defined as renal failure. So creatinine greater than 3 times the baseline, creatinine greater than 4 with the acute rise of at least 0.5, urine output less than 3 milliliters per kg per hour for 24 hours, and urea for 12 hours, or initiation of dialysis. So this is just the baseline characteristics of the patients that were enrolled. It was pretty even distribution. And then this is still the baseline characteristics. I just wanted to point out that patients that were already enrolled already had an increase in serum creatinine, if you look at the averages for the patients. And so patients could be enrolled on this trial at any time. They did not come from the ER. They could be on the floor or from the PACU. So it was encouraged that the study drug was the first pressor that was used, but however, in emergencies that required immediate treatment, they allowed open label vasopressor use. So from this graph, 348 people were receiving open label vasopressors at time of randomization. So here are the outcomes. Primary outcome was renal failure-free days for the first 28 days after randomization. You can see that there's really no difference between the 4 groups. And then this is, actually, hold on. Okay, sorry. So this is just the primary outcome again. This looked at survivors and non-survivors. And then I think I have to go. All right, so this is the results, kind of some different results. So again, we're looking at the survivors who never developed kidney failure, pretty much the same results between vaso and levo. The mortality between both groups, 63 out of 204 in the vaso group, and 56 out of 204 in the levofed group, so not much of a difference. But what I thought was interesting was the use of renal replacement therapy in the group. So 52 out of 205 people in the vasopressin group required dialysis, and 72 out of 205 in the levofed group required dialysis. So then, so this looks further at the data. So this shows that patients that were treated with vasopressin had lower serum creatinine and higher urine output as well. So again, the primary outcome, there was no difference in acute renal failure 28 days post-randomization, but there's clearly differences in the data here. So this is just going back to the definition. So there's a lot of different definitions that they use to define acute renal failure. So the patients that were in the vasopressin group, they had lower serum creatinine, higher urine output, and required less dialysis. But they had an equal amount of patients that ended up with acute renal failure. So this just kind of plays on whenever data is converted into binary outcomes, information is lost. Basically, this is saying yes or no. So if an example would be a patient that has a creatinine of 4 and a patient that has a creatinine of 10. There's clearly a difference in those 2 patients, but according to this data, they're the same. So then it's looking at steroids. So in steroids, there was no difference in mortality or median time to shock reversal. But there was trend to requiring lower doses of vasopressor, and there's going to be another trial called the adrenal trial that's coming out to look at that. So So the limitations of this study, I thought that it was interesting that the majority of the people in this study were exposed to vasopressors prior to randomization for upwards of 3 to 3.5 hours. The initiation and rationale for renal replacement therapy was not controlled. It was at the physician's discretion, and it didn't list why a patient was started on dialysis, so it's unclear. The ambiguous definition of kidney failure, serum creatinine and urine output were only measured in the ICU. Once they were transferred out, those data points were no longer measured. There was no long-term follow-up. The study stopped after 28 days, and then there's need probably for a larger randomized control trial. So now, is there a paradigm shift? Between the VANISH and the VAST studies, they both showed that vasopressin versus Levophed for first-line septic shock treatment, there was no increase in mortality, and that there was no increase in adverse events. So it just kind of poses the question if there's some patients that we see maybe would respond better to first-line vasopressin versus Levophed. Like in the patient that has AFib with RVR, typically we use neosynephrine. Would vasopressin be a better option for them? Just one thing that I wanted to point out is, so one thing for the adverse effects was there was an increase in digital ischemia in patients with vasopressin. And you need a central line for vasopressin because phentolamine will not reverse it if there's extravasation. So, the conclusion, does vasopressin improve kidney function? I think I would have to say yes. This is now the 5th randomized control trial that supports that creatinine and urine output improves on vasopressin. And then is Levophed the first line pressor for septic shock? Could it also be vasopressin?
I think you said this. What was the dose range of vasopressin that was given?
For this study, it went up to 0.06.
So they titrated it in this
study? Yeah, they titrated it. But on some of the other studies, they went as high as 2 units per minute.
That's even higher than
Yeah.
Wait, that's 0.2.
Yeah.
That's 4 times.
It went in 0.0.
Yeah.
Yes, I would say excellent job. Nice interview. But this, would you say this is a negative study or a positive study from the conclusion that they all made?
I don't know.
It sounded as though when they say that there was no the early use of vasopressin compared to norepinephrine did not improve the number of kidney failure-free days. I think that sounds like more of a negative study. Is that true?
I think she said looking at primary outcomes, you didn't see a statistical difference, but I think
She just likes vasopressin.
well, from what I understood, if you just looked more like focusing on renal replacement therapy
Right.
needed and some of the numbers that way, but not in terms of primary endpoint with renal failure at 28 days is a negative study.
And I take away from it that it's just one more study adding to the body of evidence that it's probably not harmful, not any more harmful than Levophed. And it may be as effective, but it didn't show that. It didn't show that major primary outcomes here. And remind me, was the renal replacement therapy one of the a priori endpoints that they looked at? Did they say that they were going to look at that ahead of time?
No.
Now, you had a slide up for this one.
Right before this one? This one?
Now, I thought it was interesting when you started saying that there may be different patient populations that different pressors would be better to apply. Now, for a long time, I would try to make a sequential initiation of pressor scale, and I think it still exists in the environment. And it was always confusing me while I would run these patients that the nurses had titrated these different, like it'd be like a little dose of 3 pressors instead of max dose of 1 pressor. And that was so confusing because I always think the nurses, it'd be better for you to just use 1 pressor, not go to 3 pressors. So that would And I remember nurses bringing me to the bedside and showing me that there's these patients just respond completely different to different pressors. But as a doc, you know, we don't see that a lot. We just come by, see the patient, keep rolling, and then we say these things to the nurses, and then they're there with them for 8 hours or 12 hours in a row. But that's real. Like, I think there are different patients that respond to pressures differently. We don't have a good understanding of that. And so if somebody could further that work to help them be more predictable, I think that would be a advance. So I was curious when you start talking about
So from the nursing side, one of the other issues with vasopressin is that we usually start off at the max and leave it. Like, there's not much titration anywhere except down. So if you have a patient who's not responsive to it, it's like once it's on, yeah, it's on. You have to move on to the next one fairly quickly.
Yeah, these studies titrate to blood pressure levels, whereas we use it as a standard.
Yeah.
Yeah.
Set dose, we don't titrate vaso.
I was wondering how you guys feel about that, using vasopressin at the first line, because I remember that. Deviated.
Now that comes out of Survivor Steps campaign recommendations for pressor board group, which is outdated at this point. It's 2008, so they need to publish a new version of it, which is coming. We keep hearing that they're going to publish that in September. They got pushed back after Sub 3 got pushed out and created havoc in the sepsis world. So remember, we're going to try to release it as a single gene. So maybe that'll take this up. And it seems like every, you know, it's publications around pressors and the right dose and ordering, and they just keep coming out.
Yeah.
But nothing ever just really stands out as this is they fall in and out. It used to be we were pushing a lot of them. Now everybody thinks you kill people with dose. And phenylephrine had a time when it was used heavily in the line and it got pushed out. And so you just see every about 8 to 10 years there's a shift in the ordering and encouragement with not a lot of things to grasp. So I don't know what the right answer here, other than that there's probably going to be, as we improve our hemodynamic state monitoring, we'll probably just start to see some medications select patients. I was also interested if they have this trial design with hydrocortisone.
Yeah.
Yeah, that's interesting.
Didn't really see any reduction in ICU length of stay or duration of pressor, even though they added on hydrocortisone.
Right.
And that they didn't really bear into that very much, though.
No, they didn't. No, they just said that there was no benefit, really. They really didn't talk about it much at all.
Makes me wonder if they were powered adequately to, because if they were, then that would be something to speak to. Hey, hydrocortisone doesn't do it. Because right now there's believers that if you volume resuscitate and then you should add hydrocortisone in these patients, with the thought that you're going to reduce the duration of their pressors and their length of stay. But didn't see that.
So in the days we were doing levo non-weight based, we kind of fell into the habit of kind of adding vaso when we hit 10 mics of levo or 12 or something like that. And I feel like we don't really have a standard way we do it as a group now that we're in weight based, and I see it just not added sometimes or added at low doses. So I don't know what the answer to that is.
Okay, so
Yeah, so if we're going to continue to use pressures that we have, is there a magic number when you should add it when your levo dose hits X?
I thought it was greater than 50% of the dosing range of a pressor you had the second one.
Well, we did it a little different with vaso. We kind of called it a 1 and a 1A. We just add it quicker to help with all these different things.
I think that's a process also that's specified in the sepsis order set, but I don't think you'll see that detail in just the order of the pressures alone.
And to what end does that benefit? So if you take one group of patients and you add vasopressin at half max dose of levo, take the other group and don't, what do you think is going to happen? And it's always taught that it'll help reduce your levo difficulty. And then we're running this back and forth about, well, if that's the case, and it's the intent, should we be weaning the levofed off first and then just leaving the vasopressin? I see variation around that. We see some people adding it, vasopressin, and then weaning it off first, or stopping it first, and then weaning the levo off. And what is the benefit conferred around that if you're just getting levo off first? And this would suggest that if you're swapping the levo for vaso under that first line, half dose levo maxed out, add vasopressin, wean the levo on first. I think the thought behind that was that that might be renal protective. And so the question this raises is it really improving any of the primary endpoints? Is there a need to do that or not? What do y'all see as nurses that it's sure there all the time? Yeah, I think there's a difference there. You're gonna leave over right there, but you're not.
I always do basic ones. But, cause I've always felt like I had the least room to work with. So essentially, once they got down to vaso, I mean, some people were on or off, and I would usually on or off or then titrate if they didn't respond to it. But just because you didn't have that much room, just save the cost. I don't think I really had a good rationale.
I think the logistical also play a role because they influence how we take care of the patient. For example, the titratability, one of the reasons why we picked levo as the first pressor instead of vaso is you can titrate a little bit further. It can be used without a central line. So I think for the broad cohort of patients, I think levo, in my opinion, is still the best first pressor, and then you can more narrowly define which medication would be right for the patient as you go forward. But I think levo is still the best first line. And speaking to adding a second pressor when you hit 50%, again, logistically, even if it's not for a medical purpose, such as one of the ones up there, I think that having a second pressor at least hanging and ready if you're escalating past 50% and not getting to max dose of the pressor, then starting to add a second one is just a safe, I guess, practice, even if it's not a good medically backed practice.
Should we switch to using vaso in our AFib RVR patients rather than neo?
The problem is that most of them don't have central lines. So in the acute phase, when they're decompensating, you don't want to do peripheral vaso on these people.
It's just a good excuse to do a lot.
Exactly.
I think that signal about the peripheral ischemia, though, is at least bears mentioning again.
Yeah.
That's a significant cause of morbidity, if not mortality. I mean, it's not inconsequential if you lose a finger or multiple fingers or toes.
Yeah.